There's one up top.
There's one up there.
Since you're in the area.
On me.
Thank you.
I'm confused because his head is tilted to this side, and on the slide, shouldn't it be the side that they tilted towards that is the
Not always.
side?
Because we haven't done the assessment of his jaw yet. Because remember, even though the tissues and the soft tissue structures and the muscles can be elongated, let's say we haven't thought about anything, or when he's sitting in class, he's constantly like this.
Or even like, I know when I drive, I sometimes, because I'm sitting in traffic, I tend to.
Yeah, so if you're putting pressure on the jaw, so those structures can be overstretched in the inferior aspect, but we can still have restriction in the joint capsule.
Okay.
Right? So even though he's showing elongatedness on one side, it's just showing us that there definitely is a dysfunction. What that is, we still need to do more assessing to really get a good idea of what's happening. Good question, though. All right, so first and foremost, we're going to do that little assessment of the jaw range of motion. All right, so Byron, I'm going to get you to very slowly open your jaw and close. All right, so somebody with a good quality camera, go ahead and come position yourself right here. Good. No, get down, 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 down. You are going to want to be able to see up a little bit higher. There. Okay, faster right there. Okay, go ahead, Byron, and open your jaw. And close. Good. And you can actually see in this video as well, too, his jaw actually is like deviated this way, even just in resting neutral. Okay, and one more time, Byron, open your jaw. And close. Perfect. Thank you. So that actually reflects what we're seeing in his tissues. So he's elongated in this side here. His jaw deviated drastically towards the other side. So the side that it deviates to is the hypomobile side, and the side that it deviates away from is the hypermobile side. Now, considering this is where we've already decided his overstretched tissues are, that makes sense.
But then the affected side should be this side, no?
Correct. That's where the restriction is. But the elongated tissues, I was saying, that doesn't necessarily mean that this one might not be the restricted side, because there could still be a restriction in the joint. But our assessment shows us that this it really is overall the hypermobile side, the overstretched side. Right? So that's why, even though we can suspect and then we can anticipate, that doesn't mean that that's what we're actually going to see until we assess it. Right? So I had a hunch this side would be the overstretched side, but so it just goes to show dysfunction that the patient is feeling can be on the approximated side, or it can be on the overstretched side. Right?
So what's the affected side in this
His
case?
affected side, where he's experiencing symptoms, is his hypermobile side. But maybe the cause of his discomfort is the dysfunction that's happening with the hypomobility on the restricted side.
Why not the
So
hypermobility?
what is your affected side now for treatment?
The affected side for treatment would be the side that your patient is complaining of.
Okay.
The side that your patient is complaining of with symptoms. Just like we were talking about in that neurofascial lecture, person deviated on the table. We don't know if it's going to be their approximated side that's complaining, or is it going to be the overstretched side that's complaining. It could be either or, right? Same with this. We don't know if it's going to be their approximated side where they're feeling their dysfunction. So in the purposes of board exam, you treat their unsymptomatic side first. But for the purposes of restoring our dysfunction, we know we need to address this left side of his because of how much things deviate that way.
What's his complaint, by the way? Complaint?
His complaint or his complaint side.
Complaint.
Yeah, what are you feeling on this right side here?
It's just achy.
Achy on right, right?
Yeah.
Oh, okay.
So
that's
he has
complaint.
issues on the right side. But you
Yes.
guys saw how far his jaw deviated over to the left?
Yeah.
All right, so let's go ahead and see if we can give him treatment specific for this, and then I'll quickly go into the glides. Okay, nice big breath in. And out. So good news is we can treat the unaffected side first, because my clinical brain says the unaffected side or unsymptomatic side for my patient is problematic, and therefore I'm going to treat it, right? But if he was complaining about dysfunction happening on his left side, and that was the side it was deviating towards, and for the purposes of board exam, you're going to treat his right side first, right? Good, nice deep breath in and out. Now, in terms of where restriction is, it's actually not so much in the lower portion of his neck. That's actually not that bad. Elsewhere in the neck, It feels like it's coming from the anterior aspect. Nice big breath in. And out. Good, nice and gently. I'll get you to go ahead and try and hike your shoulder up on this side. Hold for 5, 4, 3, 2, 1. Let go. Very good. Okay, so I'm going to try and expedite this treatment. So Byron, it's not going to be the most relaxing treatment. I apologize. But it should be effective. Be sure to let me know if anything feels uncomfortable, okay? So once I've done some work into the upper back, into the shoulders, a little bit behind the jaw. Now, before I get into the actual muscles of mastication, one area that I find is super tight for individuals who are experiencing dysfunction in the TMJ is right behind the angle of the jaw. So right in this area here is usually very tight, very tender for people. Take a nice big breath in and out. Good, relax your jaw. Very good. Get them to relax a little bit, nice and gently, Byron. I'll get you to go ahead and clench your jaw. Hold for 5, 4, 3, 2, 1. Let go. His left side is super tight. Good. Let that go. Relax your jaw. Good. And again, go ahead and clench your jaw and hold for 5, 4, 3, 2, 1. Let go. Breath in. And let that go. And let your jaw slacken. Very good. Yeah, so I was tucked in behind here. You can use your thumb. Sometimes I go in with my fingers here, but often I will actually tuck like this, and that will actually almost jam your thumbs into behind their ear. So go ahead, let it out, let it out, let it out. You get it?
Is that by like the thyroid process?
Yes. And actually, fun fact, that will sometimes cause people to cough because it feels like a tickle in the back of the throat. Is that what was happening?
Yeah.
Yeah, so that is actually very common. So maybe explain that as part of the discomfort that they might experience. Yeah. Good. Let go of your jaw, let go of your jaw, let go of your jaw. Not really a gliding. I'm right now hooked on to the posterior aspect of the ramus, and as he's relaxing into those structures, he is letting his jaw kind of drift forward. Let go of the back of your jaw, let it go, let it go, let it go. Excellent, very good. So it's kind of like you're engaging the tissues, he's relaxing, and we're trying to challenge the joint to move even further. Okay, so right now I'm going to focus on trying to just get these structures on this side to let go. And then we'll see if that has done anything for his deviation. Nice big breath in. And out. You okay? Good. Drop, drop, drop it, drop it. Let your forehead go. Excellent. Good job. All right. So another place that I'm going to work into eventually, I just want to show you guys where it is. Usually, this is one of the few places I actually use lotion and oil, is along the inferior aspect of the mandible because it gets a little like grippy in the skin there. So I often one side and then the other will trace along the inferior aspect of the mandible until I get to that attachment of the digastric. Good, and then I'll get them to just swallow. Go ahead and swallow, and then they'll push out with that digastric, and then feel your jaw relax and relax back. Good. You're okay? Good. And nice and gentle, go ahead and swallow again and relax your jaw. Let it sink, let it sink, let it sink. And the bottom of your jaw as well too. And falling back, falling back, falling back. Excellent, good job. You okay?
Yeah.
Good. All right, so then extraoral structures, definitely gonna work into the temporalis. I like to do more fascial work, and with the temporalis, I don't do a whole lot of direct work. So I find basically the attachments of the temporalis, and I'm going to load in terms of pressure. I'm like enveloping it, if you will. Kind of imagine the deltoids. I'm actually like enveloping the attachment point. So enveloping that, and then I'm gonna get you to nice and gently clench your jaw. Hold for 5, 4, 3, 2, 1. Let go. And let it relax. Let it relax. Good. Soften your forehead. Very good. So you can do stripping in this area. You can do bear claw if you wanted to. Right? So anything that actually specifically targets the structure here. You could go into the actual condyle itself to actually get some release happening, and go ahead and just clench your jaw there. Hold for 5, 4, 3, 2, 1, let go, very good. So remember, for the purposes of OPs and for anything related to board exam, treat the muscles of mastication, okay? It's a really good head, neck, and shoulders treatment, but focusing primarily on those muscles of mastication. If you have time, get into those hyoids. All right, one more time for the temporalis. Go ahead and clench for 5, 4, 3, 2, 1, let that go. Good, soften it, let it go. Good. All right, we'll go into the masseter.
Can you do that technique on this side too?
I'm not doing a lot of work on this side just because it's already overstretched.
Okay.
So that's why I'm doing most of the work on the side that's affected. So again, finding, you know, where our temporalis attaches to.
Yeah,
So
yeah.
literally you're just gonna envelop and contact that. So you can actually see the temporalis bunch up underneath my hand. Slowly clench your jaw. You see that contraction right there? So that's how you know you're on it. Good.
And how, what are you just pushing it down?
And literally, I just like challenge it. It's trying to flex against me.
Okay.
Hold it for 5 seconds. When he relaxes, it will melt away, and you basically follow it like you're trying to almost stretch it. Right?
Yeah.
All right, and then the same idea in with the masseter. First, I want to check. Go ahead and gentle clench. And relax. And again. Interesting. And again. Yeah, this one's very delayed. Okay, and go ahead and clench again and let go. Good, and slow clench and hold. 5, 4, 3, 2, 1, let go. Good. Awesome, and this one you can go along the muscle fiber directions if you wanted to. And then where's that attachment on the where's the extraoral attachment of that medial pterygoid? The angle. All right, so you find the angle. You can go just anterior to it, just superior, posterior to it. And if you get them to just clench, there you will find that attachment of that pterygoid. Okay, so, and that one is definitely tight on this side. So we're gonna tuck in. If you would like to be able to gain more access to this pterygoid, all you need to do is slight laterally flex away, and that opens up so you can get in and tucked under that mandible. Good, go ahead and clench again. There it is, right there. Nice breath in. And out. Good, and go ahead and clench your jaw and hold for 5, 4, 3, 2, 1, let go, and relax. Good. So with that, you can also use that slight capital extension will also let you get tucked in behind that ear a little bit more so. I'm gonna do that one more time, and then we're gonna get into the intraoral structures. I am going kind of fast because I would like to show you guys the things. Nice breath in. And out. Good, drop, 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 drop. Excellent. And then it was medial glide, and which one? Medial glide, and can somebody see what the small screen says beside it? Posterior? Okay. All right, so the way that it is described to do the medial glide of the mandible, I don't like the way that they describe it, so I'm gonna show you the way that I like to do it that is less uncomfortable to your patient, and then I'll show you the McGee method, which it shows direct from McGee, which 100% if somebody has TMJ dysfunction, it's gonna be uncomfortable. All right, so medial glide of the mandible is literally you're gonna be challenging the condyle to drift medially. Nice and easy, right? So the way I like to do it to decrease the amount of discomfort, I'm going to stabilize underneath the back of the occiput so their patient's head stays nice and secure. I like to actually envelop the entire mandible, if you will. So I'm taking broad contact, but my thumb is definitely up close to that condyle because that is where we would like majority of our mobilization to be. I'm going to be stabilizing this other side of his head with my forearm so I don't push his head over. Okay, and then I'm gonna first get him to breathe and go ahead and relax. And when he relaxes, I'm going to glide his jaw sideways. Are we doing okay with that? Thumbs up? Cool. Good, and let that go, let that go. Good, we can turn this into a little bit of a PNF. I'll get you to try and laterally glide towards me. Hold for 5, 4, 3, 2, 1. Relax, breath in. Give him a second to relax, and when he relaxes, we go further. Go ahead and try and lateral towards me. 5, 4, 3, 2, 1. Relax, breath in and out. Good. And then do a little bit of oscillations at the end there. All right, you okay?
Yep.
Good. All right, before I go into demonstrating how it's actually supposed to be done according to McGee, we're going to do the intraoral stuff just so we don't have to get him flipped back onto his back. All right, Byron, so we are going to be moving on to the intraoral aspect of our treatment. I told you for this one it will require me to put a glove on and use a finger in the inner portion of your cheek. This portion of the treatment is usually quite uncomfortable for people because it does require me to put a finger in the inside of your cheek. Do you have any questions about this portion of treatment? Do I still have your permission to continue with this? Perfect. Okay, so depending on the size of you and depending on the size of your patient, you might want to opt for a pinky. I generally use my middle finger for this because I can get right up in that corner. My index finger, sure, but I find the more reach of the middle finger is more effective for me. So a couple things you want to keep in mind. I'm going to show them what not to do first, and then I'm going to go into how to properly do it, okay? Okay. It's just uncomfortable on the cheek. So first and foremost, with this, Byron, because I am going to be inside your jaw with my finger, it's going to be hard for you to use that pain scale with me to let me know where we're at. So I'm going to get you to use your fingers to give me a score out of 5 to denote your pain, or you could even just give me a thumbs up or just wave if you need me to stop anything. Okay? Any questions about that hand scale that we're going to use? Awesome. May I continue? Awesome. Okay, so I'll get you to go ahead and open your jaw. Eyes stabilize underneath the back of the neck, and go ahead and open up. And you trace along the inside of their cheek, and this is what you don't want to do. Okay, so keep in mind you want to come at an inward angle so that you're not hooking on their cheek. From here, you'll land on that aspect of the corner there, and you can either use an external thumb if you would like to do kind of like a pincer grasp, if you will, or you could, if you want, use your thumb to create a backing of where you're applying your pressure. So right now I'm doing like a this on the inside of his cheek. Okay, nice big breath in. And out. Good, so just a gentle pressure release. Sure, you could strip the muscles if you want, and it's not gonna be very comfy. I'm a big fan of just utilizing a pressure release here. Okay, my directional pressure is kind of diagonally up towards his condyle. Byron, I'll get you to gently clench your jaw for me, please. Hold for 5, 4, 3, 2, 1, let go, good. And we can guide that to relax, and I'm just pressuring. That's a 4, so I'm backing off. We're okay here? Good, nice big breath in. And out. You're okay with my finger hovering right there? Okay. Good. And now my pressure is gonna go, when he clenches, there's like a ridge of one of his muscles that pops out that you can like land your finger on. That's gonna be super tender, but you do want to land on that ridge. So go ahead and clench your jaw, hold for 5, 4, 3, 2, 1, let go, breath in, and let this part here relax. Good, let it go, let it drift. Soften your cheek, soften your cheek. There you go. And nice and gentle, I'll get you to try and gently open your jaw. Hold right there for 5, 4, 3, 2, 1. Relax, breath in, and out. Very good. Okay, let go. Excellent. Okay, I'm gonna go ahead and remove my finger from your jaw, okay? Good. Awesome. You okay?
Yeah.
Good. All right, so how tender was that? Pretty tender. In fact, you might want to actually give your patient a Kleenex because they might actually get a little bit teary because it really sucks. All right. So now just with that, so we did all of the soft tissue work on the side that we wanted to address. Now is the time that we would go ahead and do our mobilizations. All right. So Byron, we're going to be moving on to the mobilizations component. For this, actually, let's do posterior glide first, and then I'll show you the way McGee does anterior glide. So for a posterior glide, thank you, appreciate it. Oh yeah, it's that one. Nope. So for this one, you actually need to landmark, excuse me, on the actual condyle. And that's what makes this one uncomfortable, is because we are doing a direct joint mobilization, you're gonna have to hook your thumb on the condyle of their jaw, of their mandible. And for this one, it is a posterior glide of that joint. And you can see how his facial expression is changing because of how tender that is. I really dislike that these mobilizations have you putting pressure directly on the joint that is causing them pain. So I like the more indirect approach of doing these mobilizations. Hence why I showed the medial glide as the one where I'm enveloping the entire jaw and mobilizing with the jaw, which is technically indirect because I'm not directly on the joint. And for posterior glide, instead of putting pressure directly on the condyle, pushing posteriorly, I would actually, if they're okay with it, utilize the anterior aspect of the mandible, but of course that also will require extra consent, and you need to be careful not to compress that mental foramen because that's blood supply. So do your best not to compress that. Okay, so posterior glide, according to McGee, you're actually on the condyle and you're mobilizing that condyle posteriorly. What I like to do is, I'm not going to actually go ahead and do it, but I envelop and I actually try to drive that condyle backwards utilizing the body of the mandible. Okay, it's usually less uncomfortable for the patient. It may not be as an effective direct glide, but it still is challenging that joint, and it's probably going to be more tolerable, aka less resistance will happen with your patient because it's less painful. Now this medial glide of the mandible. Okay, so Byron, for this one we are going to be demonstrating it. I'm going to try not to push very hard because I know how uncomfortable it's going to be, but it will require me to put pressure directly over top of this. Well, I mean, like, that's your affected joint, so it's fine. Directly over top of the joint can be a little uncomfortable. If it's too uncomfortable, please let me know and we'll modify accordingly. Do you have any questions about this technique so far? Awesome. Do I have information to continue? Awesome. You can actually probably put your shirt back on if you would like, and I'll just go ahead and remove this pillow for you. Because we're going to get you sideline anyway. All right, so since we're going to be trying to mobilize that way, Byron, can I get you to lay on your side facing that way, please? And then we'll put this here so you can rest your head. All right, so for this one, there's a couple reasons why I don't like McGee's version, is because you have them side lying and you're going to be pushing this way, right? So that means I'm theoretically going to be pushing the opposite condyle into the table or the pillow, right? So technically, according to McGee, what you're supposed to do is you're supposed to landmark on the condyle and literally glide medially. So let me know if this gets too uncomfortable, okay? So he kind of needs it, so go ahead, relax your jaw. Good. Good, we're okay? Thumbs up, thumbs down? No answer? Okay. Okay. He's not out cold, so it's good. Awesome. You okay?
Yeah.
Good. Not exactly comfortable, is it? Nah, really not comfortable. So for this one, they want you to put pressure directly on. What's the difference between a medial glide and a lateral glide?
Which side?
Oh wait.
Well, if I'm doing it on the other side, it's still a medial glide.
You have to go through the mouth.
Correct. A lateral glide is applied intraorally towards lateral. Okay, so this is a medial glide. If I was going to apply a lateral glide, I would actually be on the inner aspect of the condyle pushing out.
Okay. So
Right?
you didn't do that.
No. He, if anything, needs his other one pushed. Lateral glide. So we need a medial glide on this side, lateral glide on the other side to encourage that way movement. Does that make sense? Okay. Let's go ahead and reassess and see if we did anything. Alright, can I get you to your back, please? Thank you. Alright, let's get into our... Get a little bit higher so you can see this jaw. There we go. And okay, so Byron, go ahead nice and slowly open your jaw. Okay, so instead of it deviating right away, it actually kind of centered back at the end of there. Let's get a little bit closer and zoom in if you can. Good. And let's try one more time, Byron, nice and slow. So deviation happened later in the movement and it looked like, one more time, Byron? Yeah, there's a little, it comes back a little bit at the end now. So yay, it's not just a straight diagonal line one direction, and it doesn't happen as quickly. So we know we are influencing his deviation. Keep in mind, he's been dealing with this for like heckin' long time, so one treatment is not gonna fix it, but we've just shown that we've influenced the mechanical dysfunction just by addressing the components of the TMJ. Now, I would further this treatment by actually going in, treating the actual hyoids. I probably would go in and do a lot more specific work. And you know that traction of the mandible? I would actually probably focus on stabilizing the hypermobile aspect and trying to traction the hypomobile aspect to get more mobility there. But I assure you, that one's real uncomfortable. Your patient is gonna make some faces. All right, so any questions about all that?
Posterior glide, how do you know if they need it? Like, because you can't tell if their mandible is moving. Oh.
You actually can. So you can actually feel for movement with opening the jaw when you have your hands over top of the condyles, right? So go ahead, Byron, I'll get you to slowly open your jaw. And I felt this one initiated way quicker.
Okay.
And then this one went much further. All right, so when you, you'll know that you need to have a posterior glide applied if, go ahead and do that one more time, Byron, nice and slow. Keep going, all the way, 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 and close. And go ahead again. And close. So what's actually interesting is his hypomobile side, it actually feels like it is translating a little bit more anteriorly, so it feels like it does need to actually have a little bit of a posterior glide applied. So you'll actually be able to feel in their movements which one is moving more or not enough. Okay, because keep in mind, in order for it to displace anteriorly, there's a chance that one will go further or one won't go far enough. So that's when we would use those glides. Right, so it's just mechanical assessment.
Okay.
Yeah. Okay. Good question. Any other questions about this condition? All right, so as I've mentioned many times,